multiple nearby problems is not the most, I would say, less common than a bloodstream infection. But then we got two very interesting pieces of information. One of them was that this gentleman was from the Middle East, and the second was that he had drank an unpasteurized milk previously. And I think we oftentimes talk about like clinical problem-solving diagnoses and some of these rare infections that come into play. And while it's fun to consider these in a case conference setting, these don't always come up to the top of our mind in the real world authentic setting. And so we got to kind of go through the exercise of saying, okay, I have this information in the back of my head. When do I pull it into the fold here? And I think once we got the signal that this patient was from an area that has a risk factor for diseases like brucella and tuberculosis, we started to consider those heavily. We ultimately found out that the alk phos was actually with an elevated GGT. So it was a hepatobiliary process, and the patient was diagnosed with ultimately disseminated brucella infection or brucellosis, causing vertebral osteomyelitis and discitis, as well as probably some hepatobiliary involvement. And so I would encourage you to go back and listen to further to the discussion around the vertebral osteo and things like that. But I wanted to actually reflect for just 2 more minutes on the involvement of the liver here with this type of infection. I think we oftentimes see disease signatures that have involvements of like lymphadenopathy. There's some elevated AST, ALT, maybe a very high alk phos, and patients might have constitutional symptoms as well. These are things like we might see in tuberculosis. We saw it with brucella in this case, and also sometimes in malignancies and things like lymphoma. And I think I've recently learned from Robbie, this idea of the involvement of the reticuloendothelial system, which is sort of just a big word that says things that are involved in the management of blood products and cell line production. And so the reticuloendothelial system in our body is usually the lymph nodes, the liver, the spleen, and the bone marrow. And if you run your head through some disease signatures that impact these, we'll see that we sort of kind of get a coalescing of these atypical infections that we think of: tuberculosis, Coxiella, Bartonella, brucella, as well as malignancies or autoimmune diseases like lymphoma, multicentric Castleman's disease, Kaposi sarcoma. And so I think what I would offer as sort of the final reflection here is to add to our vocabulary the idea of reticuloendothelial involvement, diseases that can cause hepatomegaly, splenomegaly, lymphomegaly, or lymphadenopathy, and start to organize these types of diseases together. Again, these are all going to be inflammatory diseases often. And so we can use our sort of IMA mnemonic to organize that schema. But as these types of cases come up, I think thinking about, is this a signature of reticuloendothelial involvement that we see, which again, might be cholestatic liver pattern like we saw in this patient. Splenomegaly, which many patients with brucella have, or patients with tuberculosis may have, and potentially bone marrow suppression, and to sort of use that as an organizing construct or as a new schema that we're developing. I'm currently working on developing a schema for this now that is nowhere near complete, but it has been at least a fun sort of journey to think about this new term and kind of use it as a disease signature going forward. That's all I got. I hope we have a couple discussants and case presenters by now, because that was about 9 minutes.
That's all you got? That was amazing. Thank you so much for sharing. And what a case, Simone. Thank you so much for presenting. And I think everybody were just enjoying your reflections so much that no one has volunteered to discuss or present a case. So we're still waiting, friends.
I think we were all mesmerized by that. So
exactly.
Put the pressure on now.
Anybody wants to join Jack and I? I promise we are kind people who love nerding out about medicine and do not have all the answers. Yeah, Drew, we don't bite.
I'm leaning into my growing comfort with silence in this moment, but inside I'm dying a little bit.
It's great practice for chief year. Yay. Yeah, I think Rafa and Travis have a case if somebody wants to present it, that they can share as well.
Thank you, Azim.
Yay, Azim. How's it going, friend? How have you been? It's good to see you.
Hi everyone, I'm Azim. Nice to be back. I'm in my last few months of medical school, basically vacation mode, but I'm happy to discuss today with you guys.
I can't wait. It's good to see you. And congrats on almost being done. That is so exciting. Yeah, and who wants to join Azim? And Drew, how are you doing, friend? Thanks for presenting. How was vacation, by the way?
It was good. Currently looking to, there we go. I have the case right now, Rafa, so thank you so much. And vacation was good, and now I am back in the throes of trying to find a new apartment, because going to be moving halfway across the country. So there's that.
Exciting times ahead.
Mm-hmm. Yeah, that and next week is the final bit of med school coursework that I have before I graduate and can finally say Drew Srinivasachar, MD.
Nice. Those two little letters that we all love so much.
Mm-hmm.
I've never actually heard you say your last name until today, so I'm glad you did. And now I think I know how to pronounce it.
It's pretty phonetic. Except there's no H at the very beginning of the last name, which there usually would be. It was interesting because Dr. Vig, who Kushal and I know, and I were having a discussion on this on Twitter this morning, after there was a whole discussion about this over the course of the last day. But anyway, yeah. So we do need one more discussant, and for all of you first-timers who are here, hello, welcome. We especially want you guys to come in and discuss. We have several, a veteran discussant and two great facilitators who are here to help and here to support you through getting through the case. And hopefully certainly this case is not going to be as fiendish as the ones that I usually present.
Alrighty. So I just do, yay, I can discuss and try to do teaching points. Whatever you want, Rafa.
Oh, wait. VJ.
Oh, yay, VJ!
Thank you, VJ.
VJ, how's it going?
Hello.
Hello, I'm currently a first-year medicine resident from India.
Awesome. Thank you so much
Nice.
for joining us, VJ. I'm so excited.
Oh, Vijay, one question for you. Whereabouts in India?
I'm from Bangalore.
Oh, from Bangalore. Nice. Woohoo.
Woohoo. Simone, yes, he did make me very happy.
Relax.
Alrighty, let's get started, team. Jack, go ahead and take the first aliquot. Drew, whenever the PowerPoint is up, let's get started.
Azim, do you want to join me on the first aliquot?
I would love to.
That sounds great.
All right. Just waiting for the slide to come up.
Drew, do you have the Google Doc, or did Rafa make you a pretty presentation?
I have the Google Doc.
Okay.
Travis or Rafa, is one of you able to pull up the PowerPoint slide?
You got it. I'm going to share it right now.
Sweet. Thank you so much.
How's that?
Perfect.
Great.
All right. So, chief concern for this patient, shortness of breath. I'll give you a little more. So this is a 53-year-old gentleman who presents with shortness of breath that has progressively worsened over the last month. Prior to his presentation, he could scale about 2 to 3 flights of stairs without symptoms. But now he is only able to scale 1 flight of stairs before he gets out of breath. And in addition to this shortness of breath, he also has chest pain that is central, non-radiating, and exertional, fatigue, and lightheadedness. And I am going to leave it there for now.
All right. Azim, take it away.
Yeah, so I think the first thoughts that come into my mind with shortness of breath, I think organ systems. So pulmonary, cardiac come to mind as like the 2 areas that I'm like honing in on. I think the flight of stairs, like I don't want to anchor too early on like cardiac, but even with the chest pain, the non-radiating, I feel like this is leaning right now in my mind towards a cardiac workup. I think also the age, 53 years old, I put that in like the sort of, I guess anything other greater than like 60 for me is like, you're like really concerned. But I mean, that's in an age group that my level of like caution is like raised. For maybe more classic, like ACS, or maybe like PE type etiologies. The fatigue and lightheadedness, I can't really speak towards what the lightheadedness could be, just maybe it's reaction to the other symptomology. But so outside of like pulmonary and cardiac, I'm interested to know if there's been any kind of, I guess, recent travel, because maybe there's like an infectious etiology at play. But I think right now I'm thinking like badness first, like bad things for me, big red flags for a PE or ACS. Although the time course is like probably on the subacute range. This is not something that's happened over the course of hours or days. For the last month, I should take that into account. But it could just be one of those like acute on subacute presentations. It's just gotten really worse recently. So we can dive into that. And I think the past medical history will be, for me, critical to know where we can like evaluate the patient's like risk, like if he has diabetes, hypertension, those kinds of classic comorbidities.
Love it. Absolutely phenomenal job. I think I appreciate very much the way that you're not focusing on determining the cause of the shortness of breath right now, but rather focusing on how we're going to prioritize the potential etiologies of shortness of breath. Because in reality, trying to analyze shortness of breath from a history alone is more of an exercise in framing probabilities rather than an exercise in being able to frame the diagnosis. Because without a cardiopulmonary exam, a chest x-ray, and an EKG, it's hard for us to really narrow our conversation thus far. And so what we do is we say, okay, what's my approach to shortness of breath? And taking an organ-based approach as you did is exactly how I do it. And I stratified the way that you did: heart, lungs, everything else to start. Within the everything else category is things like anemia, acid-base status. Maybe there's an abdominal process like ascites that's leading to difficulties with diaphragmatic excursion, or a neuromuscular process potentially. But all of those things, owing to their base rate, deserve to get lumped together into the everything else, because the base rate forces us to prioritize cardiac and pulmonary symptoms. And so then from there, the question is, well, gosh, how can we from a history start to prioritize heart or lungs or everything else? And your analysis is spot on to look at the features associated with the chest pain, because the features associated with the shortness of breath. Because once we have shortness of breath, what we then need to look for is who are the friends who are coming with the shortness of breath, right? Is the shortness of breath having close evening soirees with fevers, chills, and cough? Or is it going out to lunch with chest pain that's exertional in nature or lower extremity swelling? The former are going to be things that are probably going to localize us to the lung. Because if you think about it, chest pain plus inflammation, dyspnea plus inflammation, dyspnea plus pleurisy, dyspnea plus cough, these are some things that may help us increase the probability of a pulmonary process. Whereas dyspnea plus central chest pain or dyspnea plus lower extremity edema, dyspnea plus exertional chest pain, all of these things are things that start to map onto our illness scripts for cardiac problems like angina, as you mentioned. The thing that's interesting is the patient's age. They're sort of in this forgotten age range of 50s, where they're maybe not at a huge risk for cardiac disease yet, but they're not at no risk yet. And so the morbidity of cardiovascular disease or coronary artery disease and the morbidity of developing angina makes us have to have a very low threshold to go down that diagnostic pathway, as you said. And then lastly, I think the lightheadedness, if it is exertional, is an interesting feature here, because most causes of chest pain, we're gonna primarily think about plumbing and pump problems, right? Are the vessels clogged and the pump's not working well, or are the vessels clogged and it's causing angina? But when someone has exertional lightheadedness, I also bring valvulopathies into my into the forefront of my mind, specifically something like aortic stenosis. It would be very unexpected for a patient to have an aortic valve pathology at age 50, but there are congenital problems that can progress. And so I'm right there with you, thinking about the heart first, the lungs next, everything else thereafter, and specifically focusing the cardiac process on the pipes, the muscles, and then also the valves, given the exertional lightheadedness.
Poetry. And I'll give you guys some answers with regards to pipe problems or pump problems or valve problems in this next aliquot, which is going to be the southwest corner. So, medical history. He is HIV positive with a CD4 count last at 650. Viral load completely suppressed for the last 3 years. He does have a congenital bicuspid valve complicated by severe aortic stenosis and then aortic insufficiency. And he underwent an SAVR with a bioprosthetic valve about 3 years ago. He also has coronary artery disease that was treated with a coronary artery bypass that was done at the time of the SAVR. And I'm distinguishing surgical AVR versus a transcatheter or TAVR, which is now the most common of the aortic valve replacements that we do these days in the US, at least. He also has heart failure with preserved ejection fraction, and his last check, his ejection fraction was 55%, and that was about 3 years ago. He has obstructive sleep apnea, for which he is on a CPAP at night. He has fatty liver disease. He also had a dental crown that was placed about 7 months ago. In terms of medications, he is on 81 milligrams of aspirin for his coronary artery disease, Buspar, or buspirone, Cymbalta, or duloxetine, metoprolol, succinate 12.5 milligrams, Lipitor, or atorvastatin, his antiretroviral, which is emtricitabine, rilpivirine, and tenofovir, a multivitamin, vitamin D, and fish oil. And I'm going to wait until everything is put in.
You can keep going, Drew. I got you.
All right. All right. So, in terms of his social history, he is currently studying to be a social worker and he actively works with people who are unhoused. He, in terms of health-related behaviors, he had formerly used ethanol, cocaine, which he smoked, and tobacco, and he has not used all of these for the past 3 years, and he has never had any injection drug use. He has also not had any sexual contacts in the last year. He has not had any recent travel. He has no pets and has not had contacts with animals or livestock. But notably, and this was like yesterday, he does consume unpasteurized dairy products. And I am going to leave that there for now.
Oh, wow. There's a lot to discuss, my friend. Vijay.
Oh, also allergies, no known.
Thanks, Drew. I'm loving this case so far. Vijay, what are your thoughts about some of this past history that we learned? How is that kind of informing how you're thinking through this case so far?
There's a lot of information that we get from the past medical history and the health-related behaviors. So the HPI presenting with the symptoms of a classical of a cardiac disease in the background, with the shortness of breath, progressive since the past 3 months, past 1 month, with a significant history of atherosclerotic cardiovascular disease in the background, and a bicuspid aortic valve. So what makes me think is, why has the patient gotten worse at this point of time when he has already had a surgery in the past? So is there an acute to subacute process that is new that is causing these symptoms to develop? So if it is causing that, what could be the cause? So given that patient has had a valve replacement, surgical aortic valve replacement, I would think of the possibility of, is it a subacute infective endocarditis that is happening in the background that could explain all of these symptoms, with lesion at the level of the valve or at the level of the myocardium? Or is it a subacute myocarditis that is processing in this way? So where in the heart exactly are we seeing it? Or is it really in the heart is one more question. Because is it an infection? Since he's had a consumption of an unpasteurized dairy products. So like yesterday we had brucella that is having an association with unpasteurized dairy product. And it is known that unpasteurized dairy products, like we can have Coxiella burnetii that can cause a culture negative infective endocarditis as well. But coming to the retroviral status, it seems to be under control. So I'm not thinking of any broad infection or opportunistic infection in the background, but it still cannot be ruled out. And another important thing I was thinking is the dental crown that is placed, the dental procedure. So could that have been the cause for infective endocarditis? It is known the dental procedures can cause. So, social history is not really significant. And also one thing is, I'm not sure if there are protease inhibitor. I don't know where. Okay, so what I would think of is, like, is it drug induced, like coronary artery disease worsening? So we know that the protease inhibitors can also cause increase in the coronary artery disease as well. So I'm later thinking of, so tenofovir is a protease inhibitor. So I'm thinking if that is also accelerating the process of an underlying ischemia with an underlying subacute to chronic infective versus inflammatory process going on.
That was absolutely brilliant. I have very little to add. I really, really, really love how you took the past history to kind of inform your thinking about this patient. It's like, what is this background? Which in this case is very informative. And I agree with you that endocarditis is something that we should absolutely think about given the substrate. And what it does, this past history for me,
it kind of like expands the differential rather than narrow it. And that is true of like, patients with HIV. I would be curious if this patient has any history of opportunistic infections in the past. Thankfully, the CD4 count is quite good and the viral load is negative, but people who get quite sick sometimes can deviate towards like lower CD4 counts. So, and there's still like a risk. I think Anne-Marie mentioned it in the chat, is like TB, for example. So that just tells me that like, hey, this patient can have run-of-the-mill pneumonia and like heart failure exacerbation, or something more sinister or more indolent going on. And with the valve, with the prosthetic valve involved, and yes, this dental procedure, I think absolutely thinking about any of the oral fluoride, the Verdens type species to think about as well. And the other thing that I always like try to think about, what about the prosthetic valve itself, the placement of it. At times, if there's a leak, sometimes it can get complicated by like hemolytic anemias. So I'm thinking about the valve itself, and then the complications that it can become of it, or for example, as you mentioned, prosthetic valve endocarditis. And absolutely thinking about like exerted coronary artery disease, and as someone who was like 50s but with HIV, and again, like as both Azim and Jack mentioned, is that like, are we dealing with kind of worsening coronary artery disease? Are we dealing with worsening heart failure? He has OSA, and if this is someone who hasn't been able to have CPAP, for example, pulmonary hypertension is another etiology to consider. So I think just given how rich this past history is, then the next thing we want to think about is like, how can we use our exam and our labs to help us to narrow this differential and start making some diagnostic process, a diagnostic just going forward with the diagnosis, #ESL here. Sometimes I just forget my English words. So I think like with infections, like as Jack mentioned, like looking for that IMATE, is there any inflammatory processes with endocarditis? Do you see any splinter hemorrhages? Osler knows of those things. Is it a worsening murmur on exam, signs of volume overload? So I think like the exam and then our basic labs will be very informative to kind of carry us forward and see which direction we're going to.
All right. So yeah, extensive southwest corner, and we'll hopefully get a little bit more clarity with this next aliquot. So, physical exam. Vitals. Temperature of 36.4 Celsius. Heart rate of 94. Blood pressure running 110/75. Respirate not noted. Saturating 98% in ambient air.
It's always 18, Drew. You know that.
Well, I'm just acknowledging the obvious. And his BMI is 31. So when you come in and take a look at him, he is well-appearing, speaking in full sentences, not really in any acute distress. He has anictoric conjunctiva, clear tympanic membranes, and normal nares and oropharynx. Cardiovascularly, normal rate, regular rhythm. He doesn't have a clear S2, however. And he has a harsh 3 out of 6 holosystolic murmur, best heard at the left upper sternal border, radiating to the carotids, and a 2 out of 4 early diastolic murmur at the left lower sternal border, which is new. A prominent laterally displaced precordial pulse at the apex. He does not have any heaves. He does not have any jugular venous distension, and he does not have any peripheral edema. His lung, abdomen, and neurologic exams are all normal. And in terms of his extremity/skin exam, he has a well-healed scar from his median sternotomy from his prior surgeries. He does not have any palpable lymphadenopathy, and he does not have any other skin findings. And then, if it's all right with you guys, I'll also give initial labs because there's going to be a whole bunch of other studies that are going to be coming. So, white count, 5.2, with a differential of, and these are absolute counts, ANC of 3,200 with no bands, ALC of 1,400, absolute monocyte count of 300, AEC of 100, and absolute basophil count of 100. Hemoglobin of 11.6 with an MCV of 82.7 and an RDW of 15.3 and platelets of 147. On his Chem 7 or basic metabolic panel, sodium of 135, potassium of 3.6, chloride of 102, bicarb of 21, BUN of 11, creatinine of 0.77. And on his liver chemistries, AST of 40, which is a little bit above normal, ALT of 44, which is also a little bit above normal, ALK Phos of 95, which is normal, total bilirubin of 0.9, which is normal. Given that he had concern for a cardiac etiology due to his symptoms, they also got serial troponins, which were pretty much negative. It was 0.08, and then it went down to 0.06, and then it sort of creeped up back to 0.08 over a 6-hour period. And his brain natriuretic peptide, or BNP, was 106.4, where the upper limit of normal is 100. And then in terms of inflammatory studies, yes, the lab is open. His ESR was 74 with a normal upper limit of normal of 15. And his CRP is 5.89 with a upper limit of normal of 0.8. The plot thickens.
All right. We have this unfortunate for the patient and very interesting to discuss physical exam here, as well as some of these early initial lab data. Azim, I'd love to hear kind of how you're synthesizing some of these new exam findings, as well as some of the labs that we have so far.
I think my first reaction to the physical exam is while there's a lot of stuff in the cardiac we can talk about, but big picture, I think there weren't a lot of there are not a lot of alarm findings, I guess I would say, or to phrase it another way, the fact that there's negative findings of the pulmonary exam, abdominal exam, relatively speaking, even with the HENT, those negative findings are reassuring. That can still help us narrow in, I feel towards our diagnosis by I guess sort of lowering our differential things that we were initially thinking of, which is acute heart failure, for instance. Or someone in the chat were discussing if this was something with the liver being implicated, with the conjunctiva being normal appearing. But I think a lot of the meat in the physical exam would be in the cardiac portion. I feel some of those like the holysystolic murmur, that could just be from the aortic valve, or just from the patient's baseline cardiac health. No JVD, so again, that makes heart failure lower on the differential. No leg edema as well. There was no, it doesn't seem like any pleurisy was felt by the patient. So I don't know, for me, the patient's heart rate is in a good range, the blood pressure isn't sky high. The patient obviously is obese, but I guess as far as like the physical exam, like my first like big picture for me is outside of that like little cardiac aliquot, there's not much there that is like making me pivot one way or the other. I don't know if you wanted to give your sense of the physical exam and then move on to the labs, or.
No, I think I'm with you. I think focusing very much onto the cardiac exam, and I'm with you that seems like that systolic murmur is potentially, or at least very plausibly related to the known aortic or to the known valvular replacements. I'm curious what thoughts you have, if any, on the diastolic murmur, and if your answer is that like, oh, I'm not sure, that's actually excellent, and would be great to talk through. But yeah, that was something that jumped out to me in terms of the new diastolic murmur, and would love to hear your thoughts about that.
Yeah, no, I see that in parentheses. That's helpful. The new diastolic murmur. I don't know. I don't know if that would be implicated in like kind of like an endocarditis picture or not. I know. I think I remember like all diastolic murmurs are pathological. I think that's a phrase that I was told multiple times. And so that is something definitely we need to follow up on, and I'm sure an echo will be coming in the near future. Hopefully also an EKG. But yeah, I think that out of all the information in the physical exam, that probably is the one that I'd be like, at this point, anchoring on as far as like going down a cardiac pathway.
Yeah.
And then I guess oh no, that says no palpable. Yeah, I'll leave it at that.
I'm with you. I think that really is the crux of the case so far, and that is something that we can start to really maybe not anchor on now, but certainly is a point where we're going to put our flag in the ground and say, okay, we have the beginnings of a clinical syndrome starting to emerge here. And I would say everything else that's aliquot, the vital signs, the rest of the physical exam, the subtle lab abnormalities, all of those pale in comparison to the presence of this new diastolic murmur. And I think that this aliquot also highlights the challenges of stratifying cardiac pathology in patients with known prosthetic valves, because we oftentimes think of a murmur or a patient who's coming in with cardiac symptoms and has a murmur as, oh, the murmur is the signal there. But most patients who have, whether it's a prosthetic valve or, whether it's a bioprosthetic valve or a mechanical valve, will have a murmur. And so the question then becomes, well, is this the known murmur, or is this a new developing murmur, whether it's the same murmur that's gotten worse or a completely new murmur altogether? And so I think we can sort of drive home the teaching point that you made, which is that all diastolic murmurs are pathologic, and supplement that with new murmurs in patients with prosthetic valves warrant further evaluation. And so I think I would say that exactly as you said, the presence of the diastolic murmur suggests that maybe there is a pathology happening, or a new pathology of the patient's known surgically replaced aortic valve. Because that murmur there, a diastolic murmur that's early at the lower left sternal border, in the setting of somebody who has a known aortic valve replacement, makes me think about whether or not this is developing or newly increasing aortic valve insufficiency. Many patients who have a bioprosthetic valve or a mechanical valve will have some degree of aortic regurgitation, and that's normal, just a process of how we have to sew the valve in. But once it gets to the point where it's enough to create a murmur, we start to worry about there being a potential complication. So let's talk briefly about complications of prosthetic heart valves, and specifically prosthetic aortic valves. So there's a number of different complications that can happen. They start locally within the heart itself, and sometimes these complications can go systemically. But the heart will always be the center of gravity of prosthetic valve complications, and then sometimes they can go systemically. And so the local complications can be things like a degeneration of the valve, right? The valves are not infinite. They will eventually decay over time. And so years or sometimes decades out, the valve can degenerate, and that can cause pathologies like valvular regurgitation at the site of the replacement. We can also get things like obstruction forming on the valve itself, whether that's a thrombus that develops on the valve, a pannus that develops on the valve, which is basically soft tissue kind of growing around the valve itself, or soft tissue that's filled with bacteria, like an infection, exactly as you mentioned, infective endocarditis. And infections can actually erode through the valve and lead to valvular degeneration there. And so the fact that we maybe have new valvular regurgitation at the site of a prosthetic valve makes me think about there either being not an obstruction here, like a thrombus, but potentially a degeneration of the valve, whether that's just due to time or more likely an endocardial infection. And that could be causing either regurgitation through the valve itself or a paravalvular leak. And so exactly as you said, an echo will be a great way to help us investigate this. But if our pretest probability for infective endocarditis is there, we have to ask ourselves, well, what type of endocarditis is this? Is this going to be native valve endocarditis or prosthetic valve? And who the patient is, it's prosthetic valve endocarditis, which is its own category of disease that has a slightly different microbiological breakdown than native valve. In the first year after the prosthetic valve replacement, the micro is very different. Staph aureus is going to predominate. But then as time goes on after that year, the differences between prosthetic valve and native valve lessen, and they start to look like similar features. But some other bugs can cause prosthetic valve endocarditis, like Mycobacterium. If you remember one of Chiara's case presentations of a patient who had Mycobacterium endocarditis with a prosthetic valve. And so I think our pretest probability is there for infective endocarditis or an alternative complication of a prosthetic valve, whether it's just a leak because the valve is degenerating or there's the infection eroding through there. And I think we'll use things like blood cultures and an echo to go from there. But I will leave this as a teaser that the risks of, or that the potential pathogens in culture negative endocarditis, this patient certainly has many risk factors for them. And so I'm excited to see if that ends up coming up later on.
Brilliant. So given that we're focusing on a cardiac focus, let's give a little bit of cardiac focus studies as well. So EKG, since we do it in a cardiac context, normal sinus rhythm, rate of 75, PR interval of 182, and a corrected QT of 444 milliseconds. A chest x-ray was obtained, which just revealed mild interstitial pulmonary edema and no cardiomegaly noted. Blood cultures were drawn for both aerobic bacteria, anaerobic bacteria, fungus, and acid-fast bacilli, and they were negative at 5 days. And they rechecked his HIV. His viral load is still undetectable. They screened him for syphilis, which was negative. He's Hep A and Hep B immune, and he is Hep C antibody negative. And then in terms of additional imaging, they did get a repeat transthoracic echo, which showed an ejection fraction of 64%, normal left ventricle systolic function, a mean aortic valve gradient of 64 millimeters of mercury, whereas it was 15 about 3 years ago, an aortic valve area of 0.58 square centimeters, where the normal should be 1.5, and a max velocity of 5.23 meters per second, where the normal velocity should be about 2.7. He also got a cardiac CT, which showed a focus of abnormal soft tissue along the anterior aspect of the replacement valve. And then he got the gold standard definitive imaging of a transesophageal echo, or TEE, which showed a paravalvular leak at the aortic valve annulus. And I will leave it there, as the next aliquot will reveal the final diagnosis.
My friend, Vijay, what are your thoughts on the additional information that we just got?
I think the cardiac findings, the imaging helps us a lot to go into the differentials at that point. Given the physical examination of the new onset of murmur, I think that makes the infective endocarditis high in the probability, which is where we are landing up with. That is one. The second was, what was interesting was the patient having an obstructive sleep apnea and having a normal pulmonary pressures. Also on CPAP was not able to make sense of how that could happen. One. The second thing was the imaging and the labs. So what you're saying is a mild thrombocytopenia. So it could happen with, it could be happening with a bone marrow suppression, or it could be a destructive process So I'm thinking, is it because of an infection that there is a thrombocytopenia that is happening? Although there are no band cells that are there, the WBC counts look fairly okay. Apart from that, coming to the labs, there's a CRP that is elevated. So there's an acute inflammatory process that is going on. Given that we have the blood culture negative, so given the infective endocarditis being high at a differential, so this brings us to the differentials of what we call as a culture negative infective endocarditis. So the organisms, I think, so significant history would be the dental procedures as well as unpasteurized milk that could fairly help us in the probable etiologies. So it could be a brucella, it could be a coxiella, as well as Hasek organisms could do this. So those are the things I'm thinking of for possibilities of the etiological factors. And coming to the cardiac findings, so the EKG being normal doesn't give us much, but probably if it is an abscess or some inflammation affecting the conduction system, probably there's some conduction blocks or some delays with the conduction I would think of. The second thing was the chest X-ray mild interstitial edema. Given the BNP being marginally elevated, I'm thinking what could explain the interstitial edema? So is it an ongoing inflammation? Is it because of the heart that is happening, or is it something, a different process? What clinches for our diagnosis is the transthoracic echo. So all the findings are suggestive of a severe valvular aortic stenosis. So we have a mean AV gradient of 64. So it is more than 40. The aortic valve area is less than 0.8, and there is also a Vmax of more than 4 meters per second. All these suggest that there is a severe aortic stenosis. So why is there a severe AS is one thing I'd like to think. So is it secondary to the infective endocarditis that there is rapid proliferation and there is a obstruction by the vegetation? I'm not sure if that could, if the vegetations could cause such amount of severe AS. So I'm not really sure why there is a severe aortic stenosis, or is it that the valve has started to dysfunction because of the ongoing infection. So this dysfunction, we say the paravalvular leak at the aortic valve annulus. So if we are thinking of a valvular leak at the annulus, I'm not sure how it could produce a stenosis. What I'm thinking is if it could produce a regurgitant lesion more than a stenotic lesion. I'm not really sure why there is a stenosis at this point. That's all I'm able to make of.
Okay, you're so good. I just hope you just go back and listen to your entire discussion. It's really fantastic. And just from the clinical reasoning perspective, I love that the points that you pause and ask that I'm not 100% sure why this is. And I think those pauses are just so important because that just diagnostic pause, it allows you to just track that information. And if any of them become irrelevant in the future, like in a bit, then you can always like go back to it. So I love how you're tracking the things that you know and the things that you're not 100% sure. And I have, I'm just going to summarize what you taught us because I have nothing else to add. And I agree with you with all this said and done. Like given the problem at the aortic valve, we're most concerned for endocarditis type phenomena. And the first question that I ask myself is that blood culture really negative, or did we just miss an organism that can easily be grown? So when I think of endocarditis, think about infection etiologies, then usually most of the bugs grow. So did I just not capture this bug, like a strep species, for example, that might be a little less virulent? If this is truly a culture negative endocarditis, then thinking about both infectious and non-infectious etiologies, and non-infections being like the litmus sacks of the world, which we have a little less concern for here. And then the question becomes of the infections. So those zoonotic ones, as you mentioned, the Hackett organism with the newer blood culture techniques is thought to actually, it's easily more identifiable, but a great thing to consider. And then, your alloorganisms and the zoonotic infections to consider. One thing about the TTE and TEE, unfortunately, notoriously TTE and TE is really have bad sensitivity and specificity for a prosthetic valve compared to a native valve endocarditis. And at times I've seen like a PET CT be used to actually look at the heart and look at that like aortic valve bed to kind of characterize prosthetic valve endocarditis. And with the paravalvular leak, it makes me a little bit more concerned. And I love the point that you made about the ECG. This is someone that I would keep getting ECGs on to check that PR interval to make sure that you're not dealing with an aortic root abscess of some sort, given the aortic pathology you're concerned about. So I don't have an exact organism in mind. I'm just going to open it up to Jack and Azim as well. But my money is on kind of like prosthetic valve endocarditis. And I think we just need to do some serologies. I think whether this is brucella again, maybe, but that's where I'm at. Any other thoughts, Jack, as seen before? Drew, tell us more.
Azim, any thoughts?
I don't have much to add. I don't know if we haven't discussed it. I was curious, does the CRP value, out of all the labs that we were offered, I feel like out of the CRP, out of the other abnormal ones, how does that like help in your shifting towards, or adding like evidence towards it being an infectious process with the prosthetic valve, or does it not really move the needle for you?
I think for me, if it was normal, it might move the needle of endocarditis down, but the fact that it's up, I don't think it necessarily overwhelmingly, or I don't think it, for me, it doesn't outweigh the other evidence that we have, like the paravalvular leak that we see here. Sherman, I don't have anything though to add to your discussion. I think really it's just like, we're just playing a game of probabilities, and the probability says that we probably missed a culture positive organism just based on the base rate. And then we can do like the sort of fun exploration of the culture negative organisms, but really it's just a list and you test for them and see what they go, whether it's Coxiella, Bartonella, Brucella, Ella, all of them on down. And so, yeah, I'm with you. I have no idea. The patient certainly has risk factors for Coxiella and Bartonella, both Hensley and Quintana, because of the exposure to the homeless population. And then there's other risk factors for like Mycobacterium endocarditis. And so I think it sort of is like, we could just take a bunch of cards, shuffle them together and pull one out. And I would say that is what my best guess is going to be there.
Oh boy. Yes, and the next set of tests, or rather the final set of tests, are going to be a whole bunch of antibody titers, plus one other more specialized test. So they did get Bartonella henselae and Bartonella quintana antibody titers. His henselae was IgG positive at 1 to 1024, but his IgM was negative. His Quintana titer was IgG and IgM negative, interestingly enough. His Brucella titers, IgG positive and IgM negative. His Coxiella burnetii, which causes Q fever, IgM phase 2 titer was 1 to 64, and IgM phase 1 and IgG phase 1 and 2 were negative. He also got tested for histoplasma antigen, blasto IgG, coccidiomycosis IgG and IgM, Legionella IgG, an ANA, and as AMK mentioned in the chat, no, this is not a case of Whipple's disease. The Trophorema Whipple IPCR was also negative. So at this point, we were at a loss. What do we do? So the next test that was done was essentially a shotgun DNA sequencing test known as Carius, which is a sort of new favorite of the ID world. And they found that this patient was positive by PCR for Bartonella quintana. And that's the final diagnosis. This patient was given, so this patient has a doxy deficiency, so he was given doxycycline and gentamicin for 3 weeks, and then subsequently underwent a definitive treatment with repeat sternotomy and AVR with a bioprosthetic tissue valve, Warfarin was started. He was continued on doxy for 3 months post-op. And after this, he did well. No recurrence of symptoms. And I'm just going to give a little bit of teaching points before Rafa gives his more general teaching points for this case. We talked a little bit about culture-negative endocarditis, and the most common cause is Coxiella burnetii, or Q fever, but Bartonella species are the second most common identified cause. And about 60% of cases of Bartonella actually involve the aortic valve. The key risk factors for Bartonella quintana endocarditis do include exposure to populations that are unhoused or being unhoused, as in this patient, body lice, and alcohol use disorder. And associations for Bartonella henselae are patients who are male, prior cardiac valvular disease, and contact with cats, hence cat scratch fever. And Bartonella infection in the setting of HIV, especially patients who have AIDS or advanced immunosuppression, more commonly presents as bacillary angiomatosis with spleen and hepatic involvement, but there have been case reports of endocarditis as well. And infections of a prosthetic valve tend to be far more aggressive, with valve perforations and rapid progression of heart failure compared to just native valves. And serologic testing, if you can get a positive, would strongly suggest the diagnosis. And of course, treatment would be doxycycline with gentamicin for at least 2 weeks, followed by doxy for at least 6 weeks if you're stable. And if you're able to get the valve out, or 3 months if patients cannot undergo surgery or if there's infected tissue still present. So with that, I am going to now give it to Rafa for the more general teaching points. And yeah, this is a fun case.
That was a really fun case, Drew. Thank you so much for presenting. Just a shout out to Azim and Vijay for being absolutely brilliant. Such a big fan of you. Thank you for discussing. And Jack, we're just going to call you poet from now on because your reasoning is freaking phenomenal. Rafa, take us away. Thank you all for joining.
Okay, so first, thank you, Travis, for sharing the case, and thanks, Drew, for presenting, and everyone else who participated today. So we had a very common chief complaint, which is shortness of breath, and there are many etiologies. So first, we thought about cardiopulmonary processes because they're the most common. We could think about things like heart failure, arrhythmia when it comes to the heart, or pulmonary embolism, pulmonary hypertension when it comes to the lungs. But you also have to rule out other causes, for example, anemia, hyperthyroidism, obesity, neuromuscular weakness, acidosis, and anxiety. We also have to make sure to rule out life-threatening causes first. And we also have to try to localize, for example, any other associated symptoms. For example, if we see fever and cough, we could go localize to the lungs. And then most of the discussion was about endocarditis. Something that I learned through medical school is always to think about endocarditis in the setting of a fever and a new murmur on the physical exam. And then the discussion talks a lot about the predisposing factors, including valvular abnormalities, for example, prosthetic valves, which was the case, MVP, congenital heart disease, but also conditions that promote fungemia and or bacteremia, for example, IV drug use and dental procedure. So we have to think about two main etiologies when it comes to endocarditis: infections and non-infections. Infections include Staph aureus, Streptococcus, Enterococcus, and also many other bugs. And non-infections, we call that non-bacterial thrombotic endocarditis. It's sterile vegetations and arise with hypercoagulable states. For example, SLE, aka Lieberman-Sachs endocarditis, but also APLS, or underlying malignancy, especially mucinous adenocarcinoma. And then Jack taught us about the prosthetic valves complications, many of them including valve degeneration leading to valve regurgitation, but also destruction due to the venous formation or thrombosis, and also embolic event, infected endocarditis, and prosthetic valve-related hemolysis. So thank you, everyone. It was a very fun case, and hope to see everyone tomorrow.
Bye,
Thank you
everybody.
all so
Thanks.
much. It's great to see everyone. We'll see you later.